Hello, everybody. Thank you so much for coming to the Deafblind Awareness Week um, webinar and discussion about deafblindness and the experience in deafblindness in the medical field. My name is Hayel Espinal Mikoski, and I will be facilitating this discussion. And I would like to start off by acknowledging the original and true custodians of the lands on which we live, work, and play. And I will also pay my respects to their elders past, present, and emerging. First, before we get started officially, we'll have everybody just go around the room, introduce themselves, say your name, and yeah, just say your name and we'll go to the next person. So we'll start with Rodney.
Hello, everyone. My name is Rodney Basket, representing DBV.
It's Meredith speaking. We might move on to Madeline.
Hi, everyone. My name is Madeline Rich. I'm a parent of a 25-year-old man who's deafblind. He has Charge syndrome. And I'm also the president of Charge Syndrome Australasia, the parent and family support group supporting people with Charge syndrome around Australia and New Zealand.
Meredith speaking. Thanks, Madeline. And Anne-Marie.
Hi, I'm Anne-Marie Wotherrow. I'm a researcher at the University of Sydney, and I'm deafblind myself. And my core interest is in healthcare and hospital experiences of people with sensory impairments.
Thank you all for coming and taking the time. And Meredith, would you like to introduce yourself if you haven't already?
It's Meredith speaking. I'm the project manager of Deafblind Information Australia and just helping out in the background today. Thank you, Hayal.
Yeah, so perfect. Thank you so much, everybody, for introducing yourselves. And so, Madeline, you go ahead.
Thanks, Hayel. Thanks, everyone. Can I share a screen?
Meredith speaking. Yes, I'll just enable that. Sorry, I should have done that before.
I think I can. I just wanted to make sure it was okay to do that. Can everyone see that screen? And the screen says Charge Syndrome Australasia, Deafblind Awareness Week, Touch to Connect, Madeline Rich, www.chargesyndrome.org.au.
Yes, we can see it.
Thank you. So thanks everyone for the opportunity to present today. As I said earlier, my name is Madeline. I'm a parent of a person with Charge. I'm coming to you today on the lands of the Boonwurrung people, and I pay my respects to elders past and present. I'm going to share a brief insight into our experiences in neonatal intensive care unit for my son, who is now 25 years of age, when he was born with Charge syndrome, which is a rare and complex genetic condition that causes multiple birth defects and significant sensory impairments, including deafblindness. Our son spent the first 180 days of his life in NICU before he finally came home, and this presentation is about the first 3 months of his life. And I'm just trying to go down. There we go. Not long after he was born, it was suspected that he had Charge syndrome, but this was not confirmed until a few months later. We'd never heard of Charge, and there was scant information from the medical team. We were told, however, that among other things, he would be deafblind. Like many babies with Charge syndrome, our son's medical needs were complex. The first days and weeks were filled with many medical interventions and procedures such as suctioning, airway management, nasogastric feeding, blood tests, x-rays, IVs, and a couple of surgeries. Looking back on those first 3 months, I wish I'd known then what I know now, especially about deaf-blind communication, about the power of touch cues, and how important it is for babies with deafblindness to understand what's happening now and what's coming next. After being in NICU for 3 months with no discharge date in sight, we decided to reach out to early intervention services for hearing and vision. It was at this time that we met Rob Last, early childhood educator for RVIB, now Vision Australia. Rob was the first professional we met who truly understood Charge syndrome, and his guidance, expertise and knowledge in this area set us on the path forward. More importantly, though, the skills we learned from him from that day laid the foundation for our family to communicate with our deafblind son. This is a photo that shows Rob holding our son at around the time he met him. He's sitting with him in NICU next to his cot. There are several tubes attached to our son. NICU environments are some of the noisiest, brightest and most medically intense places imaginable, filled with alarms, harsh lighting and constant clinical activity. These settings are designed to keep babies alive, and they do it very well, but they're not designed for sensory and communication needs for babies who are deafblind. Rob taught us that early communication for these babies is complex. Charge doesn't just affect hearing and vision, it can also impact all 7 senses, as well as motor skills, breathing, swallowing, and even facial expression. All of this makes it even more critical to recognise and respond to early communication attempts right from the start. Rob introduced us to some simple strategies that we could use in the hospital, such as adjusting the lighting so our son could see faces or objects more easily. He also taught us that for children with Charge syndrome, communication must go beyond words. It requires a total communication approach using a variety of methods such as signing, gestures, objects, speech, and symbols. We began with facial expressions, gestures and touch, always positioning ourselves close to our son's visual field or speaking gently into his ears. We started to use Auslan Sign Language. This photo shows our son lying in his cot. His dad's face is close enough for him to touch his face, squeeze his nose, and feel his face screw up. In NICU, we were surrounded by premature babies whose care centred around long periods of rest with minimal interaction between feeds and medical checks. The focus was on conserving their energy so they could grow. Our son was born full term. He needed early intervention just as much as he needed medical intervention. This photo shows our son being supported by me to help him sit up in his cot. Hanging above his head is a toy mobile of brightly coloured soft toys in the shape of clowns. In the background is medical equipment, tubing, and nursing staff. With Rob's guidance in mind, we advocated for a more interactive environment. We asked the nursing staff for a mat so we could take our son out of his cot and play with him on the floor. Squeezed between cots and medical equipment, he lay supported by pillows and surrounded by sensory toys, all within easy reach. Despite the challenge of manoeuvring around his feeding and oxygen tubes, getting him on the floor was worth every effort. It was a crucial step in helping him engage with his environment and begin to connect through touch and play. Rob introduced us to touch cues and the power of using consistent physical signals or objects to communicate with our son. Before bath time and before removing any clothing or tubing, we gave him a small white washer to hold. This simple object became a gentle, consistent way and a powerful signal to him that a change was coming, helping ease his anxiety and prepare him for what was next. Compare this to his experiences prior to us using touch cues. I vividly remember his first bath as I gently lowered his body into the tub. His arms flailed, his back stiffened, and his face filled with fear. He looked as if he thought I was about to drop him from a great height into the unknown.
Okay, ready to go, Madeline. Thank you.
Thanks, Meredith. We also used touch cues to alert him to movement, such as a gentle upward lift before fully lifting him, or a gentle tap-tap on his body prior to therapy. These cues helped him anticipate what was about to happen and begin to make sense of his routine and surroundings. I wish I had been able to provide him care that was deafblind informed from the very first day he was born, the first moment we knew he was vision and hearing impaired. What stands out most vividly for me in those months where deafblind informed care was critically needed were the times he needed an IV catheter inserted. He had had so many in those first 3 months that eventually the veins in his arms, hands and feet became inaccessible or no longer viable. More than once, he had to have an IV placed in his scalp. During these critical procedures, as a mother, I did what I thought was right. I held him still so they could get the needle into his vein to give him the medicine he so desperately needed. I whispered reassuringly, closely into his ear, telling him he was brave, that it would be over soon, that we were almost done. Not yet knowing the power of touch cues then, our son was in an unpredictable environment, in desperate pain, and unable to move away from what was happening to him because he was being held down by his mother. All I could do was offer him words of comfort spoken into ears that could not hear. No symbols, no touch cues, no signing. Something we've learned since, and which is common among children with Charge syndrome, is their heightened sensitivity to touch, especially light or unexpected contact. This may be linked to the frequent medical procedures and physical interventions many of these children experience in their earliest weeks. Children with Charge face a wide range of challenges right across the lifespan: medical, physical, and psychological. Their learning needs are particularly unique and often significantly impacted by vestibular dysfunction, sensory processing disorders, and difficulties with sensory integration and self-regulation. Deafblind informed care from the first moment our son was known to be vision and hearing impaired would have provided critical intervention to help us help him understand what was about to happen and to anticipate events happening, no matter whether the event was a pleasant one or an unpleasant one. It would have made him feel safe in a predictable and secure environment. Every attempt made to communicate, no matter how small, added a layer to his understanding. Each layer made his world more predictable, more meaningful, helping our son begin to understand what was happening around him. This photo shows our son today. While he is literate, is bilingual in speech and sign, communication continues to be his greatest disability in adulthood as he navigates healthcare, government services, NDIS, employment, and independent living. To end on a quote from Rob Last, communication is not something we can wait to teach. It starts the moment a baby is born. And for children with charge, it must be supported with intention, variety, and love. The sooner we start, the stronger their future voice will be. If you'd like to know more about charge syndrome, we have a free online course called Understanding Charge Syndrome. It can be found at https://understandingchargesyndrome.org/, and it features the top people who know about charge syndrome around the world. If you'd like to get in touch with me or our organisation, it's Madeline Rich, m.rich@chargesyndrome.org.au. Thank you for your time.
It's Meredith speaking. Thank you, Madeline. Just one question for you before we go to the next presenter. Your son is now an adult, so that was a while ago, your experience, and being the president of Charge Syndrome Australasia, you hear the experiences of many people. Do you think there's been any shift or improvement in understanding, or do you think families are having very similar experiences to what you had?
I don't have proof. I only have anecdotal evidence, and I've tried to do some research myself. I can't seem to find any framework around sensory needs of newborn in NICU, and that's the subject we're talking about specifically today. But the impact of our children not getting good language and access and development in those early years, which really are, they are overwhelmed by medical intervention. Early intervention for them needs to be on the same level of intensity. They're just not getting those services happening quick enough in hospital systems. And as I say, rightly so, that sometimes they are very, very sick children. My son teetered between Bay 7 and Bay 3. Bay 7 was where he was very, very sick, and Bay 3 was where he was still so sick that he couldn't come home. He never got to Bay 1. And so that's just the life of children with charge. We have to work out better ways of finding opportunities and openings within their development, their medical care, that also supports their early intervention around communication and language.
Meredith speaking. Thank you so much, Madeline. Hale, are you happy for me to introduce the next speaker, or would you like to?
I can introduce them. So the next speaker is Rodney Basket from Deafblind Victoria. And so go ahead, Rodney.
I'd like to speak about my experience working with interpreters, Auslan interpreters and deafblind interpreters in hospital, as well as in GP appointments. There's a common issue for both deaf and deafblind people throughout all of Australia. However, we all have both experiences that are positive and negative. Speaking to the negative experiences, there are hospitals in Australia that won't accept an interpreter in the room. The challenges also present when a deafblind person has to stay in hospital for a period of time. And this poses lots of difficulties finding interpreters to be available throughout the day. Myself, I had both, even just in the last year, I've had both positive and negative experiences in hospital. Over the last 10 years, I've stayed in the hospital quite a few times.
and sometimes had to write backwards and forwards.
Sometimes because there were no interpreters booked or available, the only communication available to me was to write notes back and forth. This is when I was a deaf person and I only had some communication support from my sister where we can communicate in very basic Auslan. Box Hill Hospital was okay.
Again.
Yep. When the doctors wrote up the tablets and the medication charge. Sorry, interpreter error. One way we found that worked was using a device such as a tablet. Another support that I use is using deafblind communication guides to help with the communication when interpreters aren't available. At this stage, I was deaf, profoundly deaf, but had not left, not yet lost my whole vision as I have now.
I struggled with getting interpreters for an overnight stay when I had a heart operation. Today.
Well, that's one person informed to 14 years.
So I did have, overall, it was a positive experience. So there was some improvements when I went in for my heart condition to the hospital. Interpreter availability has improved. Sometimes they are available, sometimes they're not, but generally I found that they are more available for GP appointments.
Outpatients.
And also with outpatient appointments at the hospital, this can sometimes be easier. Sometimes this continues to be an issue, but overall, I've seen some improvement there. Okay, I will hand it back to you, Hayel.
Thank you so much, Rodney. I have a few questions for you, but let's wait until Anne-Marie presents. Go ahead, Anne-Marie.
If I could just, sorry, interrupt. This is Alana, the interpreter speaking. If we could just change the spotlight, please, as we've swapped interpreters.
It's Meredith speaking. It looks like I have managed to spotlight you both, so I think we'll be good to just move between the two of you for the rest of the session. So thank you.
Great, thank you.
Meredith speaking, so you can go ahead, Anne-Marie.
You're ready to go?
Hi, it's Anne-Marie speaking. So hospital experiences for people with deafblindness, not great, as I alluded to earlier. I thought first I would talk about what the research, really and briefly about what the research says, and then secondly, show you a few solutions. So the research tells us that high rates of risky behaviours in hospitals, from the hospitals, abuse, neglect, forcible restraint, dehumanisation, and really poor outcomes in health and wellbeing. And I like to talk about something called, which I call the report card. So using the Australian government's own hospital patient experience question set, we ask the question in accessible ways of people with deafblindness. And so this information covers the eastern seaboard of Australia, more than 56 hospital experiences, and a mixture of men and women, and a mixture of mostly public, but also some private hospitals as well. So let's have a snapshot here. We've got interpersonal interaction. I am heard, 6%. I am cared about, 11%. I am informed, 40%. I am known, 11%. I am treated as a human being, 17%. I understand what the professionals say to me, 11%. So I receive the right care at the right time.
So Sorry, Anne-Marie, can we just ask for, this is Charlie, the interpreter. I'm sorry to interrupt. We just need a quick pause. If we're able to slow down when we have statistics, and just to allow for a bit of time with the tactile interpreting, we just need that slightly slower. Okay, thank you. Please continue.
In terms of care delivery, I am confident in the professionals treating me. That was 22%. And here the big winner. This is the only item in which Australian hospitals seem to score a pass. I am discharged at the right time with the right plan, 50%. My personal care needs are met, 11%. I feel I am treated equally, 22%. And my hospital puts the needs of patients first, said 6%. And my hospital is well managed overall. Well, it's hard to see how you can have a well-managed hospital with this data, 6%. So this is all depressing and horrible and requires an enormous amount of system change. So we need change in the hospitals and healthcare systems themselves. We need enforcement of policies, and we need the healthcare professionals to change what they do. So what can we do to help make things better sooner for us? And the first thing is give feedback. And the second thing is be prepared. And the third thing, to pick up the rope that Madeline has thrown me, use touch messaging systems like social haptic communication to indicate what is happening and when and where. So firstly, complain. Give feedback, because most evaluation forms are not accessible. So we have to, when we have a negative experience or even a positive experience, because it's important to let hospitals know what works and what they did well. We need to let the hospitals know. So the CEO, the nursing unit manager, the patient experience manager, whoever the person is, find them, send them an email, give them a call, physically go in and tell them. And then we need to be more prepared. If you're going to go to hospital, you need to be prepared. And I will just show you.
You have the goodie bag.
Yeah.
Which is full of.
Okay, this is my going to hospital kit, which sits on the back of my bedroom door. It has tactile stickers on it, so I can feel it. It contains important things. Now, in this day and age of mobile phones containing all our information, it's really, really, I cannot stress this enough. You must have hard copies as well as electronic, because can I just tell you something? Mobile phones run out of battery. Sometimes in an accident, it won't even go in the ambulance with you. So you need to have people able to bring in a hard copy. So we have here, I have files filled with hard copies of different types of information. So the kinds of equipment I have, the kinds of healthcare information, the contacts for people. If you are on tablets, not only take screenshots of the bottles, put the packets or write down the names of the drugs and the doses that you take, because trust me on this one, if you go in and say, I take 3 of those little white ones in the morning and I take a great big one in the evening, the doctor does not know what you are talking about. So you will waste valuable time, which could have been spent communicating with you. So be prepared. Have these things in a bag. We also have, what have we got here? Okay. I am a great believer in identifying the need to, alert other people in a hospital, because your record doesn't go with you to X-ray. It goes electronically, but the radiographer doesn't know that you have deafblindness. So I always, great fan of wristbands. You can buy orange is the best color. You can buy plain ones, and you can write on them what it is, how you identify, and what you need. You don't have to put anything on them that you don't want to. This is a pure choice. Always have and the deafblind manual alphabet. If you use that, it's always handy. Have several copies of the deafblind manual alphabet. Is that the right one? Yep. Because hospitals are places where things are lost, not just body parts, but bits of paper, bits of cardboard, information. So we have to kind of be on top of having enough information to support our stay. And also
Health haptics.
okay, this one is the social haptics, healthcare haptics card. And haptics is really great because that touch messaging, it doesn't replace the need for an interpreter or a communication guide or assistive devices with speech to text or whatever it is that you need for informed consent. What it does mean is that at 2 o'clock in the morning, when you're woken up and you don't know what for, a haptic message can say, the nurses come in with the put their arm around their hand around your upper arm, and you know that signifies the blood pressure, temperature, wound check, oxygenation that's going to happen. You can also do needles. So in the web between the thumb and forefinger, wait a minute. In the web between the thumb and forefinger, you can press, and that signifies an injection is coming. And then you point to the site. So if it's in the arm, you can press on the arm, in the abdomen, or for a new drip on the back of the hand. This was really, really important because in the research, every single person felt that they had been assaulted when somebody pushed, shoved, poked them, and then gave them a needle they weren't expecting. So these are really simple ways that we can do things for ourselves, is to go into hospital prepared and prepared to teach people. And the other important thing to remember is that the families and friends need to be involved in this, because sometimes we're too sick to do this work. So we're too sick, we're ill, we're injured, we've been operated on, we're on whoopie-doo great drugs making us sleepy. So we are not always in a position to be able to provide this kind of constant education service to the hospital from our bed when we're not well. So our friends and families need to be on board and helping.
You've also got your pens and your paper and your
Oh yeah,
blackboard.
sometimes golden oldies are good. If you've got a little bit of vision, you can use pen and note paper. We use a thick signal pencil pen, or you can use, these are great, $2 shop, mini whiteboards with thick markers, and they can be useful if you've got a little bit of sight. So that's just a sample, but basically my message here is hospital experience is truly appalling, but we need to harness our own resources, be prepared, give feedback, and use touch messaging systems, and to give ourselves a bit of a better chance at a better outcome.
Thank you. Hi, speaking. Thank you so much, Anne-Marie. That was very, very well spoken. And I find myself agreeing with everything that you said, everything that everybody said here. As a deafblind person myself, who's experienced the medical system, the healthcare system since the moment I was brought into this world in a very unique way, I can definitely empathize with most of everybody's experiences here and what you presented. I definitely appreciate it. So I'll go around with some questions. I'll start with Rodney. Rodney, what have you done not just with interpreting and so on, but what have you done to prepare yourself for hospital stays or medical appointments and so on in order to uh, present to the doctor your medical needs or your communication needs? I'm sorry, your communication needs.
Ah,
Rodney speaking.
I'm not going for
The most important thing for you for communication is to get there with a comm guide so you've got some communication support. But as for hospital, I'm not really sure.
I'll speaking. That's fair enough. And that's why this webinar is being presented, is to not just educate the healthcare system about deafblindness, the deafblind community, and what that community needs, but also for other deafblind individuals to learn and arm themselves. Anne-Marie, what has, how should I say this? So your personal deafblind experience, how has that influenced what you do in your research, as well as what have you learned from other deafblind individuals about how to gather those tools for a better hospital visit?
Anne-Marie speaking. I think it's my lived experience has really helped in, number one, recognizing that traditional research hasn't reached out to deafblind people to gather the stories in the first place, principally because of time, money, and a belief that it's all too hard. So being able to push back against that's been really important. So some of my work, which I wasn't expecting to do, has revolved around challenging the way research is done to say, if you have people with any kind of communication disability, you have to meet their needs and adjust what your methods, adjust your ways of communication. So from where I've been, sometimes been, I call it a negotiation, because sometimes I've got my communication needs, and then you've got somebody whose story you're getting about their hospital experiences. And so we've got to negotiate how we talk to each other. And that's been a fun challenge at times. So it's all about saying the methods that we use in research are not like they should not be set in stone. They have to be flexible. And one of the core beliefs that I struck early on was that using interpreters, right? I had to train an interpreter for the research, and that was the only only interpreter I was supposed to use, so that there wouldn't be any contamination of the research by the interpreters. And I just went, what are you talking about? Interpretation is an act of trust. And it's also reality for many people with deaf blindness. And so therefore to put a foreign person in that is to do an injustice. So I pushed back against all that and said that, the way deafblind people navigate socially and in various institutions is often using interpreters. So therefore, we're going to use the people that they trust. And that was one thing. So that's where the experience that I've had enabled me to say, the research systems, because the research is a system, is wrong. So just like the hospital system being ill-informed and inadequate, so too can the research system. So it's been really important to have, and I've been constantly learning along the way too, that, you know, my participants taught me so much. When I started my research, I thought I'm doing hospital experiences, and there's only one type of hospital experience, and that's in the hospital bed. But the people I was talking to told stories about being visitors and being made to wait for 6 hours for their partner to have an operation, and being fearful because it took so long. Instead of an hour, it took 6 hours. Nobody came to talk to them in the way they understood. And so that being a visitor could also be a problem. Going to outpatients could also be an issue. That people go to hospital for many different things. Some people went to hospitals in order to teach nursing how to communicate better. Some people went to hospitals as part of research programs. So that, and some people went to hospitals because their child, their partner, their parent were in hospital, and that was also an eye-opener to me, was to stop looking at people as though they only had one role to play. That, you know, people with deaf blindness could be anything, and they could be the partners, they can be the carers, and it's really important that we break down some of those stereotypes. And I think I've talked for way too long.
Hi, speaking. Thank you so much, Anne-Marie. I appreciate your perspective and how your lived experience has influenced and helped you, helped in guiding you with your research, and presenting it in such a way where it's very, very logical and straightforward. And yes, the statistics are grim, but they should drive for change and improvement.
Excuse
Thank
me,
you so much
Hayal.
for that. Yes.
Just to let you know that Rodney would like to contribute.
Go ahead, Rodney.
I just wanted to say my
I just wanted to share my recent experience when I went to the emergency department of the Royal Melbourne Hospital. It was suspected that I had broken my ankle. Unfortunately, I had to wait for a very long time for the interpreter to get me. I was told that the hospital had many failed attempts at contacting interpreters. They were trying. They were successfully able to find an interpreter by 10:30 at night. They arrived at 10:30. So I myself arrived at 10:30 at the hospital, and the interpreter could not arrive until 2:30. It was a sprain. And it turned out that I had a sprained ankle.
Hi, speaking. I can definitely empathize with you, Rodney, about needing those communication needs. And unfortunately, in Australia, one of the biggest barriers for deafblind individuals to receive medical care is the high delay in interpreting, receiving the interpreting services, and unfortunately, that's reflects onto the lack of interpreters in Australia. Well, we don't have enough.
Yep.
Also, right, and also hospitals and other healthcare facilities needing to be educated on when and how to find those interpreting services so that the patient can come through a lot quicker. and not be in so much pain for so long. Thank you, Rodney.
Anne-Marie, something to add to that, I believe.
Hi, Anne-Marie speaking. That was certainly reflected in the research in I think around 40% of the participants with sign language users, and everyone experienced the non-getting, I called it, of interpreters, that it was either too late or too hard or too expensive or nobody available. One patient spent 5 days in hospital because he had to have a special procedure that required him to be awake, and that they couldn't do it without an interpreter. So this person spent 5 extra days in hospital that were unnecessary, waiting for, and that they sent an interpreter on, I think, day 3, who didn't know how to do hand over hand, and so that was a bust. One of the things that's important is this is why I think tactile messaging systems are also really important, so that while you're waiting for the interpreter, the medical procedures can go on around you and that you're not traumatized by those. So that we do need to have other systems as well as interpreters to support communication when none is, none is available, that the staff can use tactile things so that you know that a blood test is coming, you know they're going to, they're asking you about your pain, that you can do simple tactile messaging for yes and no. You can ask a lot of questions that can be answered with a yes or no sign or touch. But I agree 129% with Rodney in that it's a huge problem that we don't have a system where hospitals understand A, how to use interpreters, and B, how to support patients when there isn't one.
It's Meredith speaking. Thanks so much, Rodney and Anne-Marie, for just highlighting some of those many challenges with interpreters. A question for Madeline, and probably everybody, is if there's a specialist that you're working with over a period of time, I'm wondering about success in building their awareness and knowledge. I'm just curious to know, starting with Madeline, but particularly a GP, if you get to know a GP and are regularly going to the same provider, if you've had any success in building their skills, understanding around the communication needs, and if you've seen changes with some people and what's worked well in that area.
It's Madeline speaking. My son never connected with a GP. He was always connected to the health system from a very early age. So his pediatrician, if you like, was actually his respiratory doctor, because he saw them multiple times in the first 2 years of his life. He had to have so much allied health, early intervention, language intervention, that we just couldn't fit in a pediatrician. And the GP that we see at the moment, and it's the case for all the specialists, is that they're time poor. In order for them to, like at this point in our life where my son's 25 and I'm trying to be just the support rather than the person advocating for him all the time in the health system, in most cases they will turn to me to communicate because they're time poor, they don't understand him, they just don't think that he has the capacity or the ability to communicate. Unfortunately, there's a heavy reliance on his listeners to enable him to communicate. And when they don't have the luxury of time to do that, then it just has to come back to the person who's supporting them. I don't agree with it. It's not right. He's going to forever need someone in those systems in order for him to be in the system. So when we do come across specialists who do respond to him appropriately around his communication needs, it's really refreshing. It's very noticeable. I thank them for it, that they've actually taken the time. They seem to have adopted strategies that they perhaps have learned along the way, but those people are few and far between, and as specialists at this time in his life, we don't see them often enough. So with those that we do see, they're getting better at understanding his speech, but oftentimes they do still rely on me to be the one to input, confirm, follow up, negotiate with them around whatever it is they're asking him to do. For example, if he was to have a blood test, he wouldn't think to ask, do I have to fast for this? They may say that to him, not write it down and expect him to hear that. He most often wouldn't have, and he then wouldn't remember to do it. And when he went off to get his blood test, even if he had heard about it, he wouldn't have thought how serious or important that was to do. So that would have been a waste of a blood test if he hadn't have fasted. It's a tiny thing, but it's impactful upon he then would have to get another blood test and an appointment 3 months down the track to have the blood analysed how it should have been tested in the first place. So minor thing, but it's a big challenge, big challenge.
Meredith speaking. Thank you, Madeline. Really good examples highlighting the issues there. So next, Rodney, have you had any providers, like a GP that got to know you, that did improve with their communication and even like showing things in a more tactile way?
Interpreters are just clarifying.
I tried that before. My job had to with me.
As I mentioned earlier, I always have to have an Auslan interpreter with me to have successful communication. And it can be a real issue when they cancel or can't find an interpreter. Because there's a lack of interpreters, as we said. I have recently moved to a new area of Melbourne. And there is one GP in my area who I've been seeing more regularly, and they have got to know me better.
Meredith speaking. What has helped? How have you felt that they know you better? What have they done differently?
Just one moment, Meredith. I'll just relay that.
Oh no.
Rodney speaking. I'm not sure. When I was there for a few times, needed a blood test recently, and I'll be here again soon, but I don't really know.
Meredith, okay, that's fine. Thanks, Rodney. And Anne-Marie, I guess from the research, I'm not sure if anything came through or your own experience, if a particular professional, a specialist or a GP gets to know the person, is there any evidence that the situation does improve with communication and that they can change and adjust a bit?
Anne-Marie speaking. No, I think there is a lot of indirect evidence in a broader population, more generally disability, that we call this concept the super team concept, that a collaborative approach of diverse professionals that you need for your care, working together so they learn from each other as well, is a really helpful. There's a lot of evidence that is really helpful. Okay, the big problem is that how do we build those kinds of teams for ourselves, and that's much harder, and getting people, and also you need someone, and I was interested in Madeline early talking about not having time to see the GP. The GP doesn't have to be the coordinator. You just need somebody, pediatrician, cardiologist, social worker, occupational therapist. You just need somebody who's motivated, who's happy to reach out to the other professionals. And you can bring people in on Zooms, or you can chat individually, or you know, but if you have particularly complex needs, you might need to meet, you know, actually have a full-on Zoom meeting. The government, for instance, recognises the benefit of what they call chronic disease management, and GPs get money to support and manage, you know, to basically be a super team leader. So you get money, so they get extra money for that. And so I think that we know that these things can work well. And if you talk to people with deafblindness who have a good system of people who work with them to meet goals and solve problems, that they talk about this, it's an overwhelmingly positive experience. So, you know, in my family, for instance, we have taught some of the healthcare providers some social haptic communication. That's been really helpful. So you can exchange information in these kind of super team kind of groups, but it's really hard. As Madeline herself has said, that they're time poor. And it's a matter of harnessing what we do have. But yes, getting people to work together collaboratively is what really helps people do better. I mean, it is associated generally with better health and wellbeing outcomes. I guess the issue when you throw interpreters into the mix, and we love interpreters, I'm not being negative here, I'm being extremely positive, that the supply and demand may make it difficult to have them when they're needed. So I guess the super team will work best when they're planned for, and that the interpreters can be there to facilitate relaying information. And it's really important because being collaborative means that you or me, us, as the deafblind people, we get involved in our own shared decision making. And you can't make good decisions if you've got bits and pieces of information only and not the full picture. So it's so much more reassuring and confidence inspiring if you feel that you're getting all the information. So I don't have, Meredith, a good solution. I can only tell you that it works, and getting it to work is the hard part.
Hi, Elle speaking. Thank you so much, you guys, for your responses. I definitely have learned quite a bit from all of you. Madeline, I do have a question for you. For any parent who's listening, what advice would you give them in order to help their child or children who are deafblind become more autonomous in their medical autonomy and their medical experiences? How have you touched on this a little bit, talking about your son and the blood testing and so on, but in other ways, how have you helped your son, and what advice would you give other parents to help them become more independent?
So if I can speak back to the infant child, so the baby, the child, and moving into adolescence, because it's to understand Charge syndrome is to really know that every sensory issue about them impacts on every sensory issue that's impaired. And they see up to 12 disciplines in the first 2 years of their life. And to try to coordinate those around a table to talk about the whole body rather than just the one organ that's not working for that particular discipline, and that parents are having to take their children to multiple appointments that are oftentimes in a major paediatric hospital, that is oftentimes in a major city, that may take them up to an hour to get to. You know, it's a big impost on their time, their life, their quality of life. And if I could perhaps put it back to the professionals and the allied health people to say, social workers, please, when you come across families that have such complex children with such complex healthcare needs that require multiple inputs from different areas, you know, the best type of service that you could be providing families is helping them to manage all of that, and so that they're able to give their time equally to every person in their family, that they're supported to have a quality of life. Charge syndrome is very hard to manage when there is lots of competing complex needs. It's a struggle to survive. You know, the burnout is real for these parents. It's a very complex syndrome. I can't impress upon you enough just by saying that. And to be able to manage that is like a full-time job. In fact, it's more than a full-time job. It's 24/7. And it's the support from the service providers that we need. Working collaboratively in the system in paediatrics, there are parts that do work collaboratively, but for our families, they need to be broader. They need to include the likes of NDIS, the LACs, the support workers. They all need to be part of this collaborative team that supports the family to put one step in front of the other. Now, once we move into adult care, the system is totally disjointed. There is no collaboration. We held off having an operation done for our son that would have given him a second hearing device that would have given him much better hearing. And he also to have another operation at the same time, because multiple anaesthesias for these children is high risk. And so the more you can have procedures done at the same time, the better outcome that we will have for the children after the operation. But it was taking us over 2 years to try and get one discipline talking to the other discipline in a major adult system hospital in the city of Melbourne, and totally delaying our son's good hearing. You know, he had the potential to get a better device to give him better hearing, and we were waiting to get these two people together to the same operation. So, you know, working collaboratively is very, very challenging in the adult system, challenging enough in the paediatric system. So yeah, it's the supports around the services, the professionals who are seeing these families, recognising how complex and difficult charge is, and taking a leap forward with them and saying, we are going to help you with this. We are really going to deliver you person-centred care around you, your child and your family.
Hey, I'm speaking. Thank you so much, Madeline. I think that you have done quite well in summarizing, but also emphasizing the importance of healthcare unity and communication, and how that can impact negatively or positively on a healthcare experience. And as a parent, that I can't imagine going through that on a 24-hour, 7-day-a-week level, and just being hyper aware of your child's medical needs, and always being prepared, especially complex medical needs rather, and being prepared for the next time you have to go back to a hospital or a health center, and just anticipating all the barriers that can come up. And it is really refreshing when we meet a doctor or a specialist or an OT or a therapist who gets it. It's all too rare for me, as somebody who's identifies as someone who's deafblind, it is all too rare to find that refreshment in the medical system. And all of you have given your thoughts in a very honest and profound way, and I certainly appreciate it. So before we close out, I did want everybody just brief closeout, and this on a somewhat positive note, hopefully. Just briefly highlight something positive that has happened to you, and in Madeline's case, to you and your son, something that has happened positively recent, doesn't have to be recently, but a nice story from a good healthcare experience. And I'll start with you, Anne-Marie. Let's keep it brief.
That's you.
Emily, speaking. I think in the research, we were fortunate enough while we were conducting the research to have some of the participants go to hospital another time. And so they were able to take with them the wristband, they were able to take with them some of the strategies that they themselves had helped to come up with. And that was really a thrilling thing to have people do well in hospital, having previously relayed several profoundly negative experiences. So it can be done. And that was exciting.
Thank you, Anne-Marie. It can definitely be done with the right tools and support. Rodney, what positive experience have you had in the past by going to the doctor or a specialist?
After some was trying to get people
Rodney speaking. We've seen a variety of different GPs for different issues through the years, and I have found that those who respond really well with having an Auslan interpreter there and work together has led to a positive experience for me.
Thank you so much, Rodney. And Madeline.
It's Madeline speaking. So a couple of quick ones. My son does have regular blood tests, continues to have regular blood tests, and he's accessing a local blood pathology centre, and they are getting to know him well, and so he feels very comfortable in that environment. They are understanding his communication attempts, and that instills in me, a sort of sense of peace that there are things like this happening more and more when people know him. He's able to, order and pick up and pay for his own medications. Technology helps him with that, but he also goes in and speaks to the pharmacy face to face. And again, it's because they're getting to know him and he's doing these things. He's taking a risk. He's coming out of his comfort zone to do these things. When we look at the hospital system, particularly in emergency and day program, day services, the people that we're seeing in there are not the same people. They're seeing multiple hundreds and hundreds of people. We're just not getting to know them. So we have to try and build that bridge to help our son communicate and access the information more easily within the hospital system. And so that's, if that's the note that we end on, how can we make that even better? I know I'll be going away and thinking about that. And I appreciate, Anne-Marie, your kit bag, which has really opened up my mind to what we could be putting in that bag that is an emergency kit for him, no matter if it is a hospital setting or going somewhere else, that it would be really worthwhile to have that, and it will make a big difference. So thank you.
Thank you, everybody, for your positive responses. I hope that the people who've listened to this webinar have learned and armed themselves with information, filled their own tool bag of sorts with the information needed in order to communicate better with any deafblind client or patient that walks through the door. You know, 3 of us in this virtual room are deafblind, and we have been able to live successful lives, independent lives, and I hope that by having this webinar, we also demonstrated that deafblind people are just like anyone else, and we deserve accessible and inclusive and not stressful medical care through whatever means we choose, whether it's a GP, occupational therapist, or therapist, um, any other type of specialist that's not directly related to the deaf or blind space. Thank you so much, Rodney, Madeline, and Anne-Marie, for taking the time, and Meredith also. And I would like to take the time to thank our 4 interpreters who have been incredible and supportive. And I hope that, also just for more information, go to deafblindinformation.org.au so that any of you listening have any questions or concerns or would like to learn more about the deafblind culture and community, please go there and learn and educate yourselves, and not just yourselves, but also the people around you. And thank you so much, everybody.
Meredith speaking. Just to wrap up, thanks Hayal and to our fantastic panel today and to the interpreters. Just to acknowledge that we've run this webinar during Deafblind Awareness Week 2025, and to wish everybody a really happy Deafblind Awareness Week. Also noting this is the first year that United Nations has ratified the 27th of June as International Day of Deafblindness. So something great to celebrate there. And thanks again to everybody.
Thanks, everyone.
Thank you.